My name is Martina Yanga. I'm the Medical Education Manager for Epsom and St Helier University Hospitals NHS Trust. I'm responsible for overseeing medical education and training in the Trust, and I'm also the supported return to training champion for the Trust. This presentation is about the structure of medical education in the UK, the current challenges facing it, and the future direction of travel. It is useful for library assistants to help them identify the resources required to support the various groups of doctors in their training pathway as they progress through their career from medical student to consultant. The outline of the presentation is as such. I'm going to talk about the structure of medical education in the UK and the recent changes that have happened, and also the future direction and the new models of training. So medical education in the UK is split into two. You have undergraduate medical education, and this includes the preclinical years where students are taught in universities for 3 years, and then they move on to clinical education where they are based in hospital sites where they learn on the job. And then there's also the MB-PhD program where those who are aspiring to become clinical teachers and professors in the future take this pathway. Postgraduate medical education takes much longer, and there are 3 pathways to that. There are those who are wishing to practice in hospital, and those are called hospital doctors. And then there are those who will become general practitioners, your family doctors. But there are also lots of other alternative career pathways for doctors. So what does postgraduate medical education look like? There have been changes since 2005. In the past, we had post-graduation. Once students finish medical school, they will go to the pre-registration year, which is 1 year, and then 2 years of SHOs. And then they become fully registered with the GMC. After that, they may choose to specialize in any of specialties. If they're working in the hospital, they may want to become physicians or surgeons, and it takes about 7 to 9 years for them to then qualify as consultants. Some of the doctors may choose to do research and education, and those ones will be practicing doctors but also will be teaching in medical schools and doing cutting-edge research in medicine. The new training pathway for postgraduate education since 2005 has changed so that the foundation program has now replaced the pre-registration year programs, and that lasts for 2 years. After the 2 years, doctors are fully registered with the GMC, and they can then go on to do core training in medicine or core training in surgery. They may also choose to train as GPs, and the GP training lasts for 3 years. Within the GP training, they will be spending some time within the acute hospitals where they do rotations in various aspects of medicine that they will see in their GP practices. They will also spend at least 1 year in the community in their final year of GP training, and after that they become registered GPs. For hospital doctors, the training takes about 8 years to become consultant. For the GPs, only 3 years after the foundation training. So there have been some criticisms about these changes that have been made. And one of the most important ones is that it has not really made much improvement to the previous system. So how is all this training regulated? We have two main bodies that regulate medical education training in the UK. So we have health education, and health education is split into 4 of the UK regions. So the one that we are regulated with within Epsom and St Helier is Health Education England. What Health Education England does is they commission medical education and training. They fund medical education and training through the Learning and Development Agreement, and that includes 50% salary support for the doctors who are training within the hospitals, and also for those training to become GPs. Health Education England also quality assures all of the training programs, and they do this through risk-based visits, action plans, education lead conversations, local faculty groups, and these are meetings that are held with the trainers as well as trainees, come together and they give feedback and talk about improvements that need to be made. The General Medical Council is the other body that regulates medical education and training in the UK as a whole. And they register doctors, they do the revalidation for doctors, which need to happen every 3 years after graduation and full registration. They also regulate professional conduct and fitness to practice. They set the quality assurance standards for undergraduate and also postgraduate medical education. And these standards are contained in a booklet called Promoting Excellence. There is the annual National Training Survey, which all doctors in the UK have to complete as a mandatory requirement to improve the quality of education in the UK generally. The GMC may also be involved in enhanced risk-based visit with health education if there are serious quality issues in a training program. The GMC now also registers all faculty trainers, that is all of the consultants within trust who are involved in training, supervision, and other educational programs within trust. So all trainers are now registered and they have to meet certain standards to be accredited as trainers. So what are the current challenges then for training? Over the last few years, there have been problems with the number of doctors going into medicine, and also those who are staying and to specialize within the UK. So there's a lot of attrition rate and a lot of doctors are going abroad after qualification. And that has raised a lot of issues in terms of gaps in recruitment and in gaps in the rotas. So there are not enough doctors to work in hospitals. Another problem is balancing junior doctors' training needs with service provision. And again, that is related to the number of rotas. So doctors who would ordinarily spend 50% of their time training are now increasingly required to provide service, i.e. take care of patients in the wards, and therefore their time for training is very much reduced. There is also a perceived creation of an underclass of untrained doctors, and these are mainly doctors who are not in training posts, and the majority of those are doctors who have qualified abroad. And so there is a perception that there's a two-tier system for doctors. A third of doctors, you may be interested to know, are qualified outside of the UK. So they contribute hugely to service provision in the UK. There's also premature choice of specialism, i.e. after the foundation year 2, doctors go into, they take various streams. So they may specialize to become surgeons or medics, physicians or GPs. And this is felt to be too soon to specialize. And of course, there is the balance between early specialism and general practice. When patients come to see doctors, quite often within the hospital settings, they're too specialized to treat patients. And so there is a need to create a pool of doctors who are generalists, who can treat any ailment that a patient comes with. The changing demographics in the UK towards an aging population is also another matter which is posing a huge challenge to the NHS currently. So all doctors now need to be trained to be able to look after older people. So care of the elderly training is becoming very much a part of the training program. So how are we responding to these challenges? So one way of ensuring that doctors get the training that they need whilst providing service is to monitor their progress very closely. And we do this through e-portfolio assessments. E-portfolio is a log of all of the training that the doctors do. They have to log everything. They have to observe procedures, and these have to be signed off by the senior doctors, the consultants. And these are recorded in their e-portfolio. And we use this to monitor and assess their progress at the end of the year through what is known as annual review of competency progression. So doctors follow a particular program and particular curriculum against which they are assessed at the end of the year, and they must pass that year to be able to progress with their training. There's also very closer monitoring of training by clinical and educational supervisors. These are the doctors that I referred to earlier who now have to be accredited by the GMC as trainers so that they're able to give effective clinical supervision when the doctors are working in the wards, for example. And then the educational supervisors take overall responsibility for monitoring the progress of the doctors throughout their training program. And this is to ensure that they are getting the training that they need. Another way of responding to the challenges is that for those specialties which are rare, there are now tester sessions that these doctors can do, ranging from 1 week to 2 weeks. And that's to give them the opportunity to find out which area of specialism that they might be interested in. So they can spend a week or two in a specialty that they're interested in and see whether that's something that is for them. Increasingly, we now have flexible working for doctors, and this is to allow those doctors, especially women who, because of the very long training years that doctors have to go through, can have the opportunity to start a family and so forth, and therefore they're very much welcome now, as opposed to in the past where doctors didn't have the opportunity to take time out of training. We also support them, and as a supported return to training champion, it's one of my roles to support these doctors when they come back from, for example, maternity leave, to make sure that they get the training that they need to then get back into training, to build their confidence, to upskill them with some of the developments they might have missed when they were out of training. As a supported return to training champion, I also have responsibility to train the consultants who are training our doctors to recognize the special needs that these doctors returning to training may have, and to help them to enter the training program successfully. So, because of the shortages of doctors and the early specialism and so forth, there has been a huge consultation around medical workforce transformation, and this is to enable those challenges that I spoke about earlier to be addressed. And out of that consultation in 2017, an action plan has been put forward and to mitigate some of these shortfalls in number of doctors. For example, there's targeted funding premium for specialties where there's acute shortage of doctors, such as in GP training and radiology. And doctors get paid a little bit more to attract them to those specialties. There is funding for their training and resources within the libraries, also to assist doctors in to go to those training programs where there aren't enough doctors. You may have heard about local education provider networks. These were meant to facilitate multi-professional education and training. This hasn't really taken off as much as it should have, and this is simply because there isn't a funding envelope attached to that program. The GP education provider networks work a little bit better than the ones in the acute hospitals at the moment. So what does this medical workforce transformation mean? There are a number of pathways that we have looked at the moment, and there is a term coined called the blue triangle. You may have seen it, and that blue triangle contains the various different groups in the medical workforce at the moment. And the blue triangle is seen as a key to solving the rota gaps and the shortage of doctors that we've looked at earlier. And its purpose is really to liberalize medical education, to offer education to more groups of doctors, for example, those coming from overseas, who at the moment are not receiving that training and opportunity for progression. We're looking at workforce transformation to see whether non-doctors can be incorporated into the medical workforce to assist the doctors who are left in the NHS do their work better. So doctors can then focus on the work that they need to do as doctors rather than spend time doing paperwork and so forth. So there are other healthcare workers who are now, for example, the physician associates and healthcare assistants or doctors assistants who are being brought in to help the doctors with that. And then, of course, there's the supported return to training, which enables doctors who have left training for whatever reason, whether to start a family or look at other careers, to come back into medicine. So if we just look at, you see from the diagram that the blue triangle has 4 elements to it. So you have the consultants at the very top. Those are the doctors who have now gone through all of their training within the UK and they're qualified as the one at the very high level. The top tier of the doctors are called consultants, and the GPs who have completed their training and are now GP partners. Below them are the junior doctors in training grades. Those are the ones within the hospital setting or in GP practices. On the left, there is the SAS doctors, and those are specialist and associate specialist doctors. The majority of these will be at consultant level, but they have trained abroad, so they are not called consultants. And then you have a big pool of trust grades. Now, these are doctors who, again, the majority would have qualified abroad, but are working at beneath the consultant level. Now, within the UK itself, there is a very large pool of trust grade doctors. These are doctors who, by choice, don't want to be in a training program, so they would have stopped at either SHO level or registrar level, and they're very happy where they are. So they do not necessarily want to progress with their training. And there are many reasons why people choose to do that. On the right-hand side of the bottom of the triangle, you can see that there's the wider workforce, and this includes professions allied to medicine, physician associates, and other scientists who work within the healthcare sector, who some of them are now assuming the role of some responsibilities that doctors used to do, but don't necessarily need to, because these are either scientists who could do tests, radiographers, and others who can assist the doctors so that the doctors can actually focus on patient care. So this is the new suggested model for training in the UK, is that whereas in the past we focused trainings very much on the training grades, now we are extending the training across the blue triangle. So the new model of education and training now looks like this. So from the foundation program, where it was 2 years post 2005, now we have the foundation year 1 and 2, and then also the foundation year 3 and even 4 in some cases, where doctors choose to take time out of training after the foundation year 2 to really experience different areas of training to see what suits them the best and which direction they would like to take. So this is in response to what we discussed earlier, that early specialism is not to be promoted, and doctors want to have a bit more time to decide which specialism they want to go into. The core medical training has also changed from 2 years into 3 years. So instead of core medical training, it's now called internal medicine training, and this lasts for 3 years. Again, this helps with the doctors having a very generalist training in the first 5 years of their post-graduation training, so that they can go through various rotations and really learn how to look after the patient in totality, so they're not specializing too early. For the core surgical training, also the curriculum is changing imminently. That's not coming into effect just yet, but again, the training for surgeons is going to be extended so that surgeons can rotate through various surgical specialties before choosing whether to be general surgeons, trauma and orthopedic surgeons, or urology surgeons. So again, the focus now is on generalism rather than specialism. For the GP trainees, the training program remains 3 years post foundation year 2, but GPs can also now have special interests in various specialties. So you may have GPs who are in the community, mainly those who are in public health, but you may also have GPs who will have an interest in a specialty, for example, obstetrics and gynecology, pediatrics, urgent care, and so forth. So these GPs will spend some time within hospital settings and take clinics with their consultant colleagues in the various areas of interest to them. And they will specialize, and they will become known as gypsies for that reason. The training program for registrars is shortened because the general training is now longer. So instead of registrar spending anything from 5 to 6 years, that training is now reduced to about 4 to 5 years maximum. There is training now provided for those doctors who are not in training programs, for example, the SAS doctors, those who are beneath the SAS doctors are now referred to locally employed doctors, in short LEDs, and these are what used to be the trust grades. There is in our trust now an educational lead for SAS doctors as well as for LEDs, and this is to promote their education in line with those of doctors in training and to ensure that they get the same educational opportunities and support that the doctors who are in training get. Because they, as you can see in the blue triangle, they form part and parcel of that triangle and they cannot be ignored. So the way that the workforce is being transformed now makes it for an inclusive training and education program where you have the consultants and the GP partners who are now qualified, delivering training not only for doctors in training, but also for the trust grades who are now called LEDs, and there's support for the SAS doctors, and increasingly also trusts are becoming much more aware of the seniority of the SAS doctors and giving them the autonomy they need to practice at the same level as consultants. And there are various charters to support this. Finally, we have the role of the STPs and the 5-year forward plan that the NHS has been following for the last 4 years. I think we've got just 1 more year to go on that one. And the STPs are sustainability transformation plans, which are regional based. And the focus is on remodeling care across the acute, community, and other areas so that there is seamless care given to a patient. So for example, if you have a patient coming into a hospital, but that patient, say care of the elderly patient who may need social care support when they're discharged from hospital, or they may need a dietitian to help them with organizing meals that are nutritious for them when they're discharged from hospital and so forth. So you have the patient is taken care of as a whole. So it's not just dealing with the medical problem, but it's looking at the care of that patient in totality within the acute and the community. So actually consultants and other healthcare workers who are involved in the care of this patient may visit them at home and continue the care at home. There are a number of community-based care provision within Epsom and St Helier, and I think we are one of the leaders in such community-led services, and that's now being rolled out to a lot of other areas within the NHS and nationally as well. The problem with the STPs is that whereas their focus is in remodeling care, what is missing there is actually the education agenda to enable all of these multi-professional healthcare workers to be able to have the education and training they need to deliver this new model of care. And that's really unfortunate. But it's something that needs to be looked at perhaps in the next round when we look at workforce transformation, how that new workforce will be trained to be able to provide that effective new model of care. As we talked about earlier, the medical education and training is funded by health education. Funding comes from the Department of Health initially, and there's something called the Learning and Development Agreement, and that's how the money flows into trusts. At the moment, there has been some reduction in the LDA funding over the last year. So from 2017-18, there was 3% reduction in funding, and there is further reduction in funding which was proposed. And this was all part and parcel of the austerity program. But it may be now that that funding may increase, but it's something that we have to have a look at. So we've come to the end of our presentation, and just to recap, we've looked at the structure of medical education in the UK. We've looked at undergraduate and postgraduate education program. We've looked at the challenges facing the medical education and training in the UK, and we've looked at the workforce transformation that's happening right now and what the new model of training and education will look like. There is a Q&A session now after this, so we're very happy to take your questions, which we'll answer through Twitter. Thank you very much indeed.